Good afternoon, good evening, ladies and gentlemen. Welcome to our session on targeting family planning, sexual and reproductive health services to leave no one behind, incentives, measurements, and results to improve equity. As we do know, there are sharp differences based on socioeconomic status, age, and region regarding access to and use of family planning. When we look at the data, approximately one-third of women in the poorest wealth quintile worldwide have an unmet need for family planning. So improving access to family planning services and commodities among the poorest, most marginalized, is crucial to improving these disparities as well as improving equity. So today, for this very, very exciting panel, you'll be hearing perspectives from the Women's Integrated Sexual and Reproductive Health Program, by FCDO, led by the International Planned Parenthood Federation and MSI Reproductive Choices across two consortia. The project has supported integrated sexual and reproductive health and rights services in countries across Africa and Asia, and you hear a little bit more about that, and does include an innovative PBR mechanism designed to incentivize a greater focus on reaching marginalized populations or groups. WISH also includes a third-party monitor, which you'll be hearing from as well, led by Oxford Policy Management and ITAD, and they lead on evidence, learning, and results verification. For this panel, with the presentations and the discussions we'll be having, it will center around several innovations implemented by both IPPF and MSI, including the MSI pioneered poverty heat maps or geospatial mapping, as well as segmentation analysis that IPPF has done to enhance the use of poverty heat maps. You will also hear about successes and challenges in achieving and measuring health equity, as well as FCDO's perspective on why leaving no one behind is an important consideration in sexual and reproductive health and rights programming. So, these very, very exciting presentations will be brought to you by my colleagues. Before I start, I am Joyce Muma, working with the Wish to Action Hub in Nairobi as Technical Lead for Monitoring and Evaluation, and I'll be your host for this afternoon. So let's kick off with our presentations. Let's not talk too much. Chris, I'll be starting with you, and Chris will be talking to us about donor approaches to incentivizing equity in sexual and reproductive health programming, lessons from Wish to Action program. Chris is a monitor and evaluation advisor at FCDO's Africa Directorate, and there he supports design, monitoring, and evaluation for programs in a range of sectors, including sexual and reproductive health. Take it away, Chris.
Thanks very much, Joyce, and good afternoon, everyone. So to set the context for our panel discussion today, I'm going to give a presentation covering how the UK Foreign Commonwealth and Development Office designed the Women's Integrated Sexual Health Programme with a core focus on reaching the poorest and most marginalised, and how we used an innovative payment by results mechanism to incentivise this focus in the programme. I'm going to cover some of the lessons we've learned about using that approach, drawing on some findings from a study that we commissioned to look into the programme's payment by results mechanism, and also bring in some of our own reflections as a donor team managing the programme. So I was going to give a bit of background on the WISH programme, but Joyce has just done that excellently. So I think all I'll do is just highlight the really impressive results that the programme has achieved over the past 4 years. So we've seen WISH reach over 9.5 million women and adolescent girls with SRHR services, and we estimate this has contributed to preventing approximately 45,000 maternal deaths. And in terms of equity, on average, around 20% of the clients reached by the programme are under 20, though there is quite significant variation across countries. Around 10% are people living with a disability, and on average, around 30% of the clients reach are people living in poverty, though again, there is quite significant variation country to country. So why the focus, the strong focus on Leave No One Behind in the WISH program? So just to kind of set out the kind of broader policy context. So firstly, the UK has a really strong commitment across its overseas development assistance programming to really target the poorest and most marginalized. So this is enshrined in the legislation that governs all of our overseas aid spending, which states that everything we spend must be likely to contribute to a reduction in poverty. WISH was also designed as the world was shifting from the Millennium Development Goals to the Sustainable Development Goals agenda, which, as we all know, placed leaving no one behind at its core. And more recently, these commitments have been enshrined in our strategy on ending preventable deaths and the recently published International Development Strategy. And as Joyce alluded to, the Leave No One Behind focus in WISH kind of also drew on evidence from previous programming and the wider evidence base, where we know very well that there is unequal access to SRH services for lower income groups, those with less years of education and those living in rural areas. And we often struggle to say across our programming if we're really reaching those groups. So in the previous program, we did start to try and monitor this, introducing the concept of high impact clients and starting for the first time to report on reaching people living in poverty and adolescents through SRHR programming. But at the time, that data didn't form part of the program performance monitoring approach. So we felt for WISH there was a really strong need to incentivize a really strong focus on reaching these clients. And that was one of the main reasons for introducing the PBR mechanism in WISH. So just to kind of talk about the considerations in the design process and moving towards using this PBR mechanism, sort of trying to explain the rationale for doing so. So WISH was being designed at a time when payment by results approaches were receiving increased attention in international development. Some proponents like the Global Centre for Development sort of believed that it had the potential to really transform the way overseas aid was delivered. And FCDO DFID at the time was a kind of an early adopter, but given the kind of relative novelty of the approach, there was quite little empirical evidence on PBR being effective, and much of the kind of evidence that we could draw on for the design of the program was sort of theoretical and conceptual, and providing funding this way to international NGOs was also relatively novel. So I'm not going to go into too much detail on this, but the theory behind payment by results, PBR, is largely derived from various fields of economics, and in particular the principal agent problem. And an academic called Paul Cliss from the University of East Anglia, who's written quite extensively on PBR, and his kind of thinking has been quite influential, has developed this model called the measure agent principle model to kind of describe the key elements of where a PBR approach is likely to work best. I'm not going to go into too much detail on this, but his papers are worth a read if you're kind of interested in more of the conceptual underpinnings of PBR. But the key points to highlight are that PBR appears to work best where you're able to measure, have a agreed measure or performance indicator that is straightforward, easy to measure and verify, and we'll come back to that. The agent, so the recipient of the funds, needs to be willing to take some form of risk. And the principal, in this case the donor, FCDO, should ideally ensure that it contracts over a long enough period of time to give space for the targets to be met. So implementing this in the reality of WISH was really challenging, and there were lots of trade-offs that we had to consider between a really high ambition that we had on reaching a large number of users, at the same time making sure that the program focused on sustainability and system strengthening, while also ensuring this really strong focus on leaving no one behind. So the program ultimately settled on a set of 6 KPIs. So 2 focused on reach or volume. So we used couple years protection and additional users. 2 equity KPIs, adolescent reach and poverty, and then a KPI linked to the approach the program was taking around policy engagement and system strengthening. And kind of other dimensions of equity and other priorities we wanted to drive through the program, like social norms change, were sort of built into the wider program monitoring framework, but weren't linked to payment in the same way as those KPIs. And the discussion today, we're primarily going to focus on around the poverty key performance indicator. So just to go into a bit more detail on the challenges around developing an indicator for poverty that could be used in a PBR approach. So again, this was really challenging, not least due to the myriad of issues around poverty measurement, which still are the discussion of large conferences among microeconomists, such as the size of ICFP. But we took detailed work in collaboration with leading experts on poverty measurement with the implementing partners at the beginning of the program to try and find an approach that would work. So the first thing we needed was a clear definition of poverty. And we initially adopted a definition based on the then $1.90 a day international poverty line, and set an ambitious target for the program where which countries were expected to reach a percentage of clients living in poverty at parity with the percentage of people living below that line in that particular country. So that was the target. The next challenge was, okay, how are we going to measure this? And inevitably, there is no kind of one ideal measure that met all the criteria we were looking for. We explored quite a diverse range of options, looking at things like whether we could fund to oversample living standard measurement surveys, DHS surveys to get that data. But ultimately, we settled on the probability of poverty index as the main tool, with some countries using the multidimensional poverty index, where kind of data for the PBI was not available. And we landed on these because they could be integrated relatively easily into existing survey tools, client exit surveys, and allow data to be collected relatively frequently, more than would have been the case with kind of national level surveys. So we knew from the start that this wasn't perfect. There are often differences at country level depending on which measure you use. I'm going to come back to some of the lessons on this shortly. So just moving on to some of the lessons, having covered the sort of design of the mechanism. So as I said, we commissioned this study through our third-party monitoring evaluation support led by ITAD and OPM. And that would kind of really look qualitatively at the PBR mechanism, try to draw out some key lessons about, okay, how's it worked in practice? So the first thing it looked at were what we call the incentive effects. So that's really the kind of programmatic and behavioral responses to the PBR mechanism from the implementing organizations. And overall, the study found that the use of PBR to focus on equity had clearly incentivized the program to make a significant effort to reach youth and people living in poverty. And on poverty reach, partners adopted a range of innovative strategies to increase their reach, including the kind of geographical mapping, which we're going to hear more about, lots of kind of data-led analysis of which channels were most effective, and also comprehensive community engagement to build demand. So that said, assessing the true impact of the program's poverty reach and attributing that to the introduction of a PBR mechanism wasn't possible with the study approach that we took. We didn't have a counterfactual. Things were also complicated by the onset of the COVID-19 pandemic, which caused significant challenges across the program. And as I've kind of alluded to earlier, there are also these issues around poverty measurement. So I'm just going to talk a little bit more about the challenges that we kind of identified and some of the tweaks that we made to the approach to try and make it a bit more sensible as we kind of learnt as we implemented the program. So I think it became clear after the first kind of round of data collection through the client exit interviews that the kind of initial consumption-based definition of poverty that we had adopted to set the target was just too blunt an instrument across a program that's operating in multiple countries with different contexts. And then, as I alluded to on the previous slide, the kind of differences that you get in poverty measurement if using different measures. So even using the MPI or the PPI would potentially give you different results in different settings. We were also kind of aware that we're relying on an annual survey that just provides a kind of snapshot at that time. which also means there's limitations. So kind of all this meant, in a way, we weren't particularly well aligned to the conceptual basis of payment by results, which is you need to have a measure that's as straightforward to interpret as possible, and you don't want to have something that means you're unsure about, okay, is the data really telling me what I want it to, or do we have measurement issues? So what we did to respond to this, so partway through the program, based on some incredibly useful and in-depth analysis conducted by the partners, we agreed to shift to using the multi-dimensional poverty index for both the measurement, but also importantly, the setting of the target. So initially we moved to that approach with MSI, and subsequently we're now rolling that out across the whole program. And that's because we think MPI is simply just a more useful way to measure poverty in the context of an SRH program. So it's standardized and holistic, and it's conceptually straightforward, and it gives you a kind of better explanation of how people are poor, the different dimensions in which people experience poverty. So that helps you sort of better target programming, enables subgroup analysis if you have sufficient sample sizes, and also allowed us to benchmark against comparable populations. So in this case, we're able to benchmark just against women of reproductive age. So I think despite all these challenges, and we've had lots of conversations and in reflection about this, having this data has still been incredibly useful to the program. And we think, we're not aware of many other programs that are conducting program level measurement in this way. So we really think that WISH has some really important learning to share here with not just the SRH sector, but more broadly. So just to move on, so the study that we commissioned also examined what we refer to as system effects. So that's the ways in which the use of a payment by results mechanism may have produced benefits or created other issues and risks for the implementers' planning, delivery, and monitoring approaches. So the study found that there were actually positive effects on program strategy and planning, such as the use of the sort of geographic targeting that we'll hear more about, and also kind of really clear evidence that it helped to strengthen data systems across the program, just given that the data was under so much more scrutiny than it otherwise would have been. And we also found no evidence of any materialization of potential perverse incentives that a PBR approach could introduce. So the study found that the mechanism didn't divert attention away from other priorities such as quality of care and making sure we kept that focus on informed rights-based SRHR provision. And then finally, we also looked at essentially the contracting modality of PBR. So how did that work in practice in terms of financial and risk management, in terms of the donor implementer relationship? So I think a key observation and reflection is that the level of risk for the program, particularly on the poverty KPI, was set too high, particularly given that ultimately the implementers didn't have control over that outcome. They can't control who comes through the doors to access their services, and their rights-based organizations serve everyone that comes. So this is certainly something that we'd take into account when designing future programming. And then secondly, I think one thing we've learned is that even though in theory PBR is meant to kind of reduce reporting burden because you just tell your implementer, okay, that's your target, go away, innovate, and will just tell us whether you've hit that or not. But unfortunately, FCDO systems don't allow us to purely do that. So there was still quite a high level of kind of focus on, kind of more standard donor reporting, as well as the kind of added complications that we had with PBR. And we also needed to introduce the sort of third-party verification into the program as well, which, while it did introduce slightly more reporting burden, it was essential for us as a donor and has added a lot of value in terms of that data system strengthening that I referred to earlier. So just to wrap up with some final reflections before I hand over to the really interesting bits of the panel, I'd say despite the challenges, the inclusion of a poverty measure was ambitious and innovative. And while the kind of evidence we have, we can't attribute any increase in poverty reach from baseline to the use of PBR, there have been those clear incentive and system effects. And I think in particular, the collection of poverty data has allowed us as a partnership to have really detailed discussions and make better decisions on how to best reach the poorest and most marginalized in the program. However, I think donors using this approach need to give full and proper attention to the design inception phase of a program to really understand and unpick those trade-offs and ensure that you come up with a set of KPIs that can accommodate the complexity of real-world programming and not be punitive for factors that are outside of an implementer's control. And you also need to stay alive to the kind of emerging risks that using PBR might bring about, as we did in WISH. So when the COVID pandemic hit, we waived the risk linked to the poverty KPI and obviously kind of listened to issues and made changes to the measurement approach to kind of take some of the issues we found into account. And just to say, despite these challenges, we think that you're still committed to kind of using PBR in our programming, and as we're designing a potential follow-on to WISH at the moment, we're thinking through how we can use the lessons from WISH to kind of really design a mechanism that works for the next program. So I'll stop there and hand over to Joyce. Thanks very much.
Chris. We'll go right over to Mathea Roma. She will be giving us a presentation on putting equity at the heart of what we do, successfully closing the gap in reaching the poor through evidence-driven programming. She is an evidence, innovation, and research manager at MSI Reproductive Choices and has over 5 years of research experience in the SRHR space. So take it away.
Thank you very much, Joyce, and good afternoon, everyone, and good morning, evening to those online. I will be building on what Chris has shared and diving deeper into how MSI has really pushed the boundaries on measuring poverty and using this data for closing the gap and reaching the poor through evidence-driven programming. So why is it that we focus on reaching those living in extreme poverty? Well, we know that poverty status is one of the biggest predictors of health outcomes globally, with substantial disparities existing in health outcomes based on socioeconomic status. For example, in Nigeria, as you can see here in the slide, women in the top wealth quintile have 64% of their demand met for family planning, compared to only 22% of those in the lowest wealth quintile. So you can see how this large discrepancy in access to family planning based on wealth quintile, and this goes beyond family planning. It is very much connected to maternal mortality. When you look at the data, maternal mortality for women in the lowest wealth quintile can be up to 82% higher than that of women in the lowest wealth quintile. Therefore, reaching these populations living in poverty is one of the most crucial gaps for the sector to be filling to ensure universal access to sexual and reproductive health services. At MSI, we have a long history of learning through programming focused on reaching rural, underserved populations. MSI's work during the WISH precursor, which was called Preventing Maternal Death, or PMD program, provided us a lot of useful insights on how to better reach people living in poverty. There are 4 key lessons that we learned through this program. The first was that providers need to be operating at scale in rural settings. Data shows that 85% of people experiencing multidimensional poverty live in rural areas. Services also need to be highly subsidized or free of charge. As service providers, we also need to be building client awareness and supporting activities aimed at shifting harmful social norms. These activities need to be tailored for different audiences and localized to each context. And lastly, we need to make sure that the services we are providing are integrated with each other, such as immunization services alongside family planning. This can reduce the number of healthcare visits that rural populations who often have to travel long distances to access a health service need to complete. And so while we learned a lot under PMD on how to reach those living in poverty, WISH posed a challenge of how to capture this, with the aim of continuing to improve our performance of these activities and ultimately be more effective at reaching this key client group. So how have we done this? Well, over the past years under WISH, we have really catalyzed our approach to measuring those living in poverty, and I'll just give you a brief overview of how this has looked. So for nearly 7 years, beginning in 2011, we collected poverty data using the Poverty Probability Index, or the PPI, as Chris introduced, as well as the Wealth Index. In 2018, with the start of WISH, we also introduced the Global Multidimensional Poverty Index, or MPI, more widely in our client exit interviews. We also piloted routine collection of the PPI in our electronic health information management system, and developed site-level dashboards to monitor our relative poverty reach across sites using this routine client data and DHS data. And using these data sets, we developed geospatial maps to have even greater oversight of gaps in our outreach operations in terms of reaching high poverty density geographies. And then moving on to 2019 to 2020, during the WISH program, we completed a more in-depth review of the two poverty indices, as Chris mentioned, the PPI and MPI, and decided that the MPI is better suited for measuring and informing MSI's programming. Through this process, we worked together with OFI, who's a developer of the MPI metric, to validate MSI's approach to national benchmarking and the use of this metric for a client exit interview setting, as opposed to the classic approach in a household survey. And currently, we have an even more exciting project under development. Beginning last year, we piloted another routine poverty measurement with the routine collection of the MPI in Nigeria. But we didn't stop there. We've also tested incorporating some of the other client exit interview questions in the randomization component of this pilot. But I'll share more on this in the next slides. So going back to two key innovations under WISH. As I mentioned earlier, MSI pioneered the poverty mapping to be able to improve the site selection and expand access more effectively to people living in poverty at scale. I have highlighted here two examples of what this has looked like in practice and the results we have seen. So first, on your left, you can see the example of Senegal, where we were able to identify areas where outreach teams could be traveling to deliver services to more clients living in extreme poverty. The pink dotted line shows our benchmark, which is the estimated national percent of women of reproductive age living in extreme poverty. And as you can see, MSI's outreach teams have been greatly exceeding this since 2017. And as you can see, with a jump from 2019 to 2020, this correlates with when we introduced these geospatial mapping. And it's contributed to more than a 2.5 increase in the percent of clients living in extreme poverty. This progress was amongst the best that we've seen in the MSI partnership and really points to the utility of these geospatial maps to guide site selection. And in Zimbabwe, we also use mapping, working in collaboration with the Ministry of Health, to be able to really understand in much more detail the areas with high density of populations and high level of poverty. Based on these maps, we were able to move our teams so they can better reach these populations. And as you can see from our data, integrating this data into the decision-making process enabled us to almost double the number of clients we reached that were living in poverty. So from these examples, we have clear evidence that if we use mapping for site selection, we can effectively improve our programming in terms of reaching a higher number of clients living in poverty. The other innovations that I mentioned earlier is our routine collection of poverty metrics. Previously, we were able to assess the wealth of our clients through client exit interviews, which provided results only on an annual and channel level basis. However, over the past few years, we have generated insights along this process of integrating routine poverty measurement into our health management information systems, or HMIS, which shows that this could be transformational for our organization. MSI has approached this work in two distinct phases. In the first phase, MSI piloted the routine collection of the PPI questions, as I mentioned earlier, using two rotating questions integrated within our outreach HMIS across several countries. This enabled us to be able to track performance by team and at the site level. Being able to disaggregate by subgroups could enable us to better select and schedule site visits, and equally importantly, supported us to better understand what interventions were or were not working. In the second stage, we have taken this to the next level. We have piloted routine collection of poverty status using the MPI questions instead of the PPI and integrated other demographic and client exit interview questions in these mix of rotating questions. This is all with the purpose of increasing data efficiency for MSI and making sure that we can generate more insights without adding further data collection burden to our clients or our providers. As part of this pilot, we also gathered further insights on the process through qualitative interviews and in-depth analysis of the routine data that have informed our scale-up approach. For example, we have found that this approach really does increase the data collection efficiency, not only for MSI, but for clients. It's reducing the amount of time that they have to speak to the receptionist or the provider. So we're not only reducing the burden for clients, but making sure that they did not find these questions sensitive. So during the qualitative interviews, we also asked them about the sensitivity of responding to these poverty questions, and in the context of Nigeria, we did not find that these questions were perceived to be sensitive to the clients. So this gives us great confidence that this could be a potential way of moving forward in terms of routine collection of poverty data. The other innovation that I mentioned earlier is our So, however, all of these things need to be brought together if we really want to maximize our impact. To begin with, by using our DHS data to develop heat maps to identify areas with highest poverty density, and then connect this with the geospatial technology so you know where the teams are going. You need to have the right metrics in place, such as in our case, the MPI. The combination of these really tells us whether we're serving those people that we intend to reach, and then connecting this data with other sources of data so we can better understand the details of how to reach these underserved populations. So by bringing these four components together, we at MSI and across the partnership have been able to better understand, using our limited resources, how to reach these clients at scale. So let me take you back really quickly in terms of what this means for our programmatic perspective. We are here because we want to close the gap in access to family planning for those living in extreme poverty, and we know why. And I want to be very clear that the evidence consistently shows that outreach is the most effective mode of service delivery for reaching this population. As you can see from the graph here, if you're plotting the proportion of clients living in multidimensional poverty by channel using our client exit interview data in 2020 to 2021, both for severe and general multidimensional poverty, we can clearly see that outreach is not only surpassing the national benchmark, but by a lot. Actually, our outreach teams reach 3.5 times more people in severe multidimensional poverty than the private sector, and 1.5 times more than the public sector. If you want to dive very quickly to a particular country, this is something that we found very fascinating at MSI. When you compare the proportion within Nigeria, for example, you're looking at the proportion of women of reproductive age that are using modern contraception and living in multidimensional poverty. At the national level, this is 16%. But if you dive into the data from MSI's outreach clients in Nigeria, 84% of our clients are living in multidimensional poverty. 5 times the proportion of FP users nationally. So what this data solidifies for us is that outreach model is the most effective for achieving this poverty reach, because we can go rural and really reach communities where there are no other providers. With that in mind, there are 3 key things that I would like you to take away from this presentation. First, to close the gaps in access to FP by reaching those living in poverty, we need to make sure that we have successful evidence-based service delivery approaches, implement better design programs, and design and use stronger performance management systems that can measure our reach of those living in poverty. MSI has made a lot of progress in this. Our approaches and data have shown tremendous success and really point the way to achieving equity for more time to come. Through which we have gladly shared innovations across partners so we can all benefit from client exit interviews to spatial mapping, setting the right benchmarks of comparison and generating actionable insights. Other partners on this panel will share more on these innovations. However, I want to leave you with one key message. Increased equitable access to healthcare is a reason we work in development. Our program's main goal should be closing the gaps and reducing the inequities that continue to exist. But measurement matters to truly know if what we're doing is truly successful. Thank you very much.
Oh, thank you, Ms. We'll move right along to Musa. Musa will be presenting on service delivery point segmentation analysis, expanding some of the geospatial work that Mathia just talked to us about, and how we use that for targeting decision-making in family planning programs. Musa, as just a brief background, is a data enthusiast with over 10 years of experience in data management, analysis, and monitoring and evaluation. He's currently our senior data analyst within the Wish Hub in Nairobi. Take it away, Musa.
Sorry. All right, thanks, Joyce. Good evening, everyone. My name is Musa Muga. I work for IPPF, just as Joyce has introduced, as a senior data analyst. today I want to share with you a simple analytical piece that we adopted to support with the targeting of intervention sites with high levels of poverty and high population density and adapt a suitable intervention to that effect. Now, to put things into perspective, I will highlight how IPPF adopted a concept of using poverty heat maps from lessons shared by MSI Reproductive Choices, who used the approach in previous programs. And I think this is just to make clear the analysis methodology that I'll explain in a couple of slides ahead. Now, picking from what my co-panelist Romy has just mentioned, poverty heat maps essentially brings together two data sets. That is poverty estimate data extracted from demographic health survey and population density data extracted from worldpop.org. And all are secondary data sets. The two data sets are triangulated, and the resulting data set, which defines our poverty heat map, then enables us to target areas of high poverty and with sizable population. Now, by overlaying our site intervention sites or service delivery points, geolocations on the poverty heat maps, it is possible to determine which intervention sites, or health clinic in this case, are closest to the areas of greatest poverty and any corresponding SRH needs, and where we could potentially run outreach services to reach these populations. Sorry, just a bit. Now, this marks the final product for IPPF. And we share this output via our resource portal for our implementing partners to use. And we define our priority areas by the red spots that you see on the map. Just to put it out there, when we finally got this product, they were a bit bulky, and we had to develop a resource portal for us to be able to disseminate the product to our implementing partners use. From this output, then, we are able to categorize intervention sites into 3 groups. So we have high priority well covered, low priority well covered, and high priority not well covered, as you can see. We are then able to understand how well our intervention sites are aligned to meet our program needs. And in this case, we are referring to reaching clients living in poverty with SRH services. The first image that should be on the left represents the most ideal level of alignment that we would aim for as a program, where we have high concentration of intervention sites in areas of high population density and high poverty. Now, as we continued to engage with the poverty heat maps in discussion on adaptation strategies to optimize reach for clients living in poverty, there was a growing interest in knowing the percentage of sites that were well aligned to priority areas as depicted by the poverty heat maps. At the same time, we also realized that we were not going to discuss these adaptations in isolation. Other programmatic areas of interest had to be considered. And in doing so, we had also to assess the trade-offs that exist between our areas of priorities. And by area of priorities, I mean our performance indicators. And that's how the idea of intervention size segmentation analysis was birthed. Now, the concept of segmentation analysis in itself is not new and has been used in other areas of reproductive health sector. For example, market segmentation, total market approach that I'm sure most of us are familiar with. Segmentation analysis simplifies the information presented in the poverty heat map such that it's easy to identify possible programmatic adaptations for increasing reach for vulnerable groups, like clients living in poverty, and at the same time assessing the possible programmatic trade-offs. In this analysis, we aim to optimize reach for clients living in poverty by targeting service delivery points or intervention sites located in areas of high poverty and high population density without compromising performance in other programmatic areas of interest. We compare site coverage data extracted from poverty heat maps, and take note that at this point when we extract this information from the poverty heat maps, the data set here has both poverty estimates and population density, which we combine using geoprocessing tools in our GIS tools, softwares, sorry. And this, the other set of data we use is our routine service volume data, which is a site-level data from routine service statistics based on family planning services offered. And this is convenient for us because most of our other KPIs are a function of service volume data. The two data sets are intersected to create 4 segments. Intervention sites are then logically clustered into the 4 segments. We present this information for consumption by our implementing partners or the hub program managers into what we call a C box, or if you wish, a Cartesian plane, where we have the 4 quadrants, and we color code each quadrant. The spots in each quadrant are actually the service delivery points. And this is an interactive dashboard on Power BI. And the full dashboard actually shows the intervention sites by name. So it makes it easier for decision making. And at the same time, it's possible to know the number of intervention sites in each quadrant. And in interpreting this, just an example, the intervention sites that will be on the green quadrant, the first quadrant, it shows that the intervention sites there are well aligned to reach clients living in poverty. At the same time, there will be the intervention sites that will give you a good volume service. The second quadrant, or the yellow quadrant, would be, or the amber quadrant, would be the intervention sites that would are aligned to reach clients living in poverty. They are located in areas that will enable you to reach clients living in poverty, but not as much service volume. Another insight would be if your program at that particular point is interested in optimizing reach for clients living in poverty, then you will intensify activity in intervention sites that are in the green and the yellow quadrant. Now, with that information, we then developed an adaptation guide. Sorry. We developed an adaptation guide which essentially it was a generic adaptation guide that was meant to guide or steer the thinking of implementation partners on how or what possible adaptations they could make. For example, in the gray quadrant, you'll have your intervention sites that were not well aligned to reach clients living in poverty, and at the same time were not giving as much service volume. One consideration that we would suggest is for them to scale down the intervention so that they can refocus the resources to the other service delivery points that are they can optimize or use the resources to optimize service delivery in both cases. Now, we measure the impact of our intervention mostly through client exit interviews, which is another great learning we got from MSI Reproductive Choices. And I'll give an example of Zambia, where, okay, so far we've had 2 rounds of CEI, and efforts and discussion were optimized to optimize reach for clients living in poverty was intensified after round 1 results for Zambia. And going by this example, after the round 1 results, we saw a shift in activities. For instance, in round 1, in rural, we had about 14% activities in rural areas. But after the discussion, after engaging the poverty heat maps and the segmentation analysis, we were able to see a shift from urban to rural. And in round 2, we saw activity levels in rural areas at around 75%, which essentially showed, and this activity was largely on the outreaches that were able to be disseminated into the rural areas. This was also evident on how activities shifted from Copper Belt and Lusaka to Southern Province, where in round 1 we had 39% in Southern Province. But as you can see, in round 2, we saw an increase in activities of 66%. When we look at the results in terms of reach for clients living in poverty, you can see the shift between the 2 rounds, which was round 1 was in 2020 and round 2 in 2021. You can see a significant change in reach for clients living in poverty from 23 to 42, almost double what we achieved in round 1. And just as was mentioned by Romea, outreach still is the best, came out as the best channel in Zambia for reaching clients living in poverty. In summary, this analysis would help implementers prioritize project intervention sites in a manner that ensures that program efficiency and cost effectiveness is maximized. Segmentation analysis tool can compare any other 2 program indicators, not just poverty and service volume, and is continuously under improvement to make it more user-friendly and usable by non-technical users. Thank you.
Thank you, Musa. Thank you, Musa. And we'll go to our final presentation for the evening. And this will be from Lamia. Lamia will be giving us a presentation on an assessment they did of experiences in collecting poverty measures through the WISH Implementing Partners routine client exit interviews. She is a senior consultant with ITAD and co-leads the Oxford Policy Management third-party monitoring component within WISH, known as WISH for Results. Thank you, Lamia.
Thanks, Joyce. Oh, God. Hi, everyone. I hope this works. Thanks for the introduction, Joyce. So I'll be presenting on behalf of WISH for Results, which is the third-party monitoring component for the WISH program. And it's, as Joyce said, it's co-led between ITAD and Oxford Policy Management. So the evidence and learning team on the WISH for Results project collaborates, oh dear, sorry. Collaborates with the WISH implementing partners, which are MSI and IPPF, as well as FCDO, to identify evidence gaps and areas for further learning that could help enhance the program implementation. So we developed discrete studies and evidence briefs, among other activities, that could help address those needs. One of those studies was an assessment of experiences in collecting poverty measures through the WISH implementing partners' routine client exit interviews. Today, I'll be presenting the findings on behalf of the study lead, Louise Berry. So as you've heard from my colleagues, the WISH program has a major focus on reaching vulnerable populations, namely adolescents, people living in poverty, and people with disabilities. The WISH implementing partners collect data on poverty and disability from service users through client exit interviews, which you've also heard a lot about. And they do that to routinely measure and report on the extent to which WISH is reaching these populations. These are collected annually and using a systematic approach to generate comparable data for the program. My presentation today will focus on how they're collecting data on poverty. So the tools used to collect the data are the multidimensional poverty index and the poverty probability index, which you've now heard quite a lot about. And the IPs have incorporated them into their client exit interview questionnaires. So these tools are some of the preferred methods among the global community due to their reliability, and they've also been applied to quite a few range of contexts. However, despite this widespread use, so far we don't know very much about the experiences of data collectors in using them, as well as the use of these tools within the sexual and reproductive health context. So the purpose of this study was to address this gap in knowledge around collecting poverty data in the context of sexual reproductive health, a context where clients could potentially be reluctant to share sensitive information, which could also lead to bias through these questionnaires. So this slide gives you some background on how the WISH implementing partners conduct their client exit interviews. So they're conducted with clients leaving service delivery sites after using a sexual reproductive health service, and they include questions about the services clients have received during their current visit as well as previous visits. The questionnaires are designed to help the implementing partners better understand how clients use their services so that they can also better meet their needs. So the questionnaires also provide important data for the implementing partners so that they can report on key performance indicators, as you've heard from my colleagues earlier. They're also quite an important tool for monitoring progress towards WISH targets and informing program strategy. So for this particular study, we focused on the sections of the client exit interview that collect data on poverty and disability. However, in my presentation today, I'll only be focusing on the poverty aspects. So to give you a little more information on these tools, the Multidimensional Poverty Index was developed by UNDP and the University of Oxford. It's an international measure of multidimensional poverty and covering over 100 countries. The tool identifies multiple deprivations based upon 10 indicators that are grouped into the domains of health, education, and standard of living, and capture not only the prevalence, but also the intensity of poverty of an individual. As for the Poverty Probability Index, that was developed by Grameen and Innovations for Poverty Action. It measures the relative poverty by asking country-specific questions about household members, assets, and household facilities, and then uses that data to estimate the likelihood of an individual falling below the national poverty line. So both of these tools were merged for the purpose of the client exit interviews. As I mentioned earlier, the purpose of this assessment was to contribute to the evidence base and learning across WISH Consortium, with the ultimate objective of improving data quality and measurement within the WISH program. More broadly, we also hoped that sharing this experience could inform other SRH implementers who are interested in collecting data on vulnerable populations that they serve right now or that they are hoping to serve. So this is an outline of our methodology. We first conducted the literature review to identify any issues related to client exit interviews in the context of sexual reproductive health. We've used this literature review to inform our focus group discussion guidelines. Then in March 2020, we conducted focus group discussions with 28 enumerators in 2 countries. These were Cameroon and Tanzania, to understand their experiences of administering poverty and disability questions as part of the client exit interviews. So through the literature review, we found no literature that had a particular focus on using the MPI or PPI within the context of sexual reproductive health. Because of this lack of understanding of the different factors that may be associated with the quality of data collection, the effectiveness and ethics of the methods used, as well as the usability of the data in the context of sexual reproductive health, we then conducted this assessment to explore the experiences of data collectors using MPI and PPI in their client exit interviews. So what did we find through our focus group discussions? We found that the enumerators felt they were well trained to conduct the interviews. They felt very well equipped with knowledge about sexual reproductive health and family planning. And also they gained the buy-in of service providers. This then helped them gain the respect and trust from clients that they were interviewing and resulted in more productive interviews. As for the implementation of the client exit interviews, we found that health service staff were perceived as being key to the successful administration of the survey. We found that data collectors felt supported by supervisors and the service providers while in the field. And we also found that the assistance of facility staff and community health workers was seen as beneficial for identifying clients and also for explaining the purpose of the survey. We also found that the health providers helped with talking to vulnerable clients. However, we did also find a number of logistical issues concerning the implementation of the interviews that affected the recruitment and data collection and therefore the ability to interview eligible clients. These included difficulty in finding suitable spaces to conduct the interviews, also problems in following up with clients in the community, resulting in some interviews taking place several days after receiving a service. This was, I should say, this was very particular to the community-based service delivery channel. And also some women didn't want to be seen or spend additional time in clinics, particularly in settings where the use of family planning is not seen as socially acceptable, which is a finding that's very specific to this SRH sector. And lastly, the lack of resources. There was a lack of resources to enable interviews with people who were deaf, mute, or preferred to speak in a local language. Around asking the poverty questions, in general, the enumerators in Tanzania found the questions on poverty, for example, those asking about living conditions, child mortality, and ownership of assets, to be overly sensitive and personal, and some felt a bit uncomfortable to ask them. In some cases, this raised feelings of suspicion and fear among clients, particularly in the context of a sexual reproductive health survey. This was also a reason why some clients declined to participate in these questions. However, in Cameroon, the enumerators did not find the poverty questions sensitive. Instead, they found them technically difficult to administer. So some problems that were reported were due to poor translation of some terms and inaccurate response categories associated with questions, particularly about ownership of household assets. The setting of the interview also highly influenced the level of accuracy on data about clients' living conditions. So for example, enumerators who conducted interviews at the household level, which was again specific to community-based service delivery, they found it a lot easier to ask these questions in situ, where they could observe and verify the client responses about household assets and materials. So based on the findings from the assessment, we made some recommendations grouped by questionnaire, training, and data collection, which I'll outline now. For the questionnaire, we recommended using the translation of questions and terms for MPPI and PPI are tested for cultural and contextual appropriateness in each country prior starting data collection. While it's important to use the country-specific poverty indicators, it's also important to consult with country-level stakeholders. And this is to confirm the accuracy of all the terms in the local context, but also to pre-test this tool in country before rolling out. We also recommended providing clearer guidance and instructions in the tools for administering poverty questions in different settings. For example, those that were administered at the household level, it would have been helpful to provide instructions for the enumerators on how to implement living standard questions by observation or to confirm the client responses by observation. As for training, the assessment suggested that it's important to include more focus on how to administer challenging poverty questions in training of both enumerators and supervisors. It's also important that the training includes a clear explanation of what each question is aiming to measure, rather than just a provision of a literal translation. Training should also reference the guidance provided by the PPI questions for each country on how to deal with ambiguities and responses that were difficult to code. We also recommended providing clearer guidance in client exit interview training for data collectors and supervisors on the importance and responsibility of ensuring quality data collection, particularly regarding consistency of data, and not to change the original meaning of the question when it's being asked. Based on this assessment, also we should identify the questions that are culturally or contextually difficult, and then in turn provide instructions for enumerators on how to handle these questions so that the responses are not biased. And lastly, provide clearer guidance to community health workers and health providers so they can effectively support the client recruitment process. Finally, around data collection, we recommended that it's important to, where possible, equip data collection teams so they can conduct interviews in secure and private areas in comfort, and also to strengthen the supervision of data collection and ensure that existing observation and feedback mechanisms include a particular focus on the challenges identified in this assessment. So in summary, we found client exit interviews to be a useful platform for sexual reproductive health service delivery organizations that are wishing to routinely collect data on poverty reach. And this assessment provided important learnings on how the multidimensional poverty index and poverty probability index questions can be used within the context of the sexual reproductive health sector. Thank you.
Thank you, Lamia. Thank you, Lamia. I think we have about 15 minutes, slightly less, for Q&A. Are there any questions in the audience for our panelists on the presentations? Yes?
Equity, because some of the approaches that you use to increase equity are more expensive than the more passive static. So I just wondered how your cost per CYP measures against other benchmarks without perhaps the equity focus. Thanks.
Thank you. Any other questions? Chris, do you want to take that?
So I don't have the data off the top of my head, but it is something that we've been tracking. And colleagues will correct me if I'm wrong, but we have seen a kind of decrease in the cost per CYP as the program has progressed. Although particularly in some really difficult to work contexts. So I'm thinking humanitarian settings like Somalia, that is areas where you do see a higher cost per CYP. And I think reflecting on value for money measurement, I think that kind of cost per outcome measure is important. But when you take equity into account, you also need to think about, okay, what's the broader value of reaching these groups? So I think that maybe the cost per CYP doesn't quite get there, but yeah, there is variation, and some of the reaching the harder to reach communities is more. But as FCDO, we're keen to support that, and it's why it's important to have that balance between the kind of the KPIs that you are tracking. Thanks.
I'd also add to that, I think does this work? On the other side of the equation, the CYPs, we tend to see that the more rural you go, the more women we're finding accept LARC methods because of the gap in the public sector for providing those services. So it might be a bit more costly to reach them, but you're getting more CYPs. So we have not found at MSI that I'm aware of any increase in our outreach in terms of cost per CYP as we've increased our poverty reach.
Thank you. Shameless plug. A buck in the back will be talking about value for money and a lot of just what your question asked tomorrow. And so maybe just talk with the buck at the back and you'll get a bit more data on that. So shameless plug. But any other questions? I do have a question for some of my panelists. I'm going to start with MSI. MSI, you talked about the challenges you faced with collecting some of the poverty data. Could you elaborate a little bit on these challenges, especially talking about routine data collection and through the CEIs? And I'm going to pick on Musa, just because I can. Musa, you gave us results about poverty reach in Zambia. Can you fully attribute improvement in reaching poverty clients to Zambia, to use of poverty heat map and segmentation analysis? Can you talk a little bit about that? I'm just picking on two today.
I can start. So we've faced numerous challenges conducting the client exit interviews, especially in our last mile service delivery channels, so our outreach providers and public sector. In many contexts, the more rural you go, especially now looking at the Sahel, the more security risk our enumerators are facing. So at times we have to make tough decisions around where we send an enumerator at the cost of likely decreasing our poverty metric. So in Niger, we've had to do restricted CEIs only on outreach teams that go in the more peri-urban areas because, of course, we prioritize our enumerator safety. We've also seen, the CEIs are just a cross-sectional survey, so we tend to conduct them in October and November of the year, and obviously that's just a snapshot of our clients reached, and there are temporal trends in where our teams go, so the sites that are being selected during that time period can influence, of course, the indicator. I think those were the key ones. And the other challenge that we faced at MSI has been around channel mix. So we've seen that while we really want to support our outreach, that sometimes you can see conflicting indicators in the client exit interviews in terms of what looks good. So we'll see with our MS ladies, we're reaching more adolescents, but they then also tend to be reaching more peri-urban clients and fewer clients living in poverty. And also we've found with data collection, the timing of where they go, if they're going to a university that week because they have a promotion there that they're pairing with service delivery, we'll find they'll have a really high adolescent reach, but that will likely skew not only the method mix, but also the poverty reach. So there are some very practical challenges in conducting the CEIs in this context.
All right, thank you, Joyce, for the question. I'm a data person. If I would quantify the causal effect of the intervention, I would, but at this point, we were not able to do some analysis to to check that. But having said that, what we know is that we did something, we changed something about our programming, and we were able to see the result at the end of it all. And also number two, CEI is a cross-sectional survey, and we know there are myriad of things that go into it that can also contribute to the changes. So with that, I can't say that 100% attribution, but we did do something that yielded some result at the end of the day. Thank you.
Thank you, Musa. I think this question to you, Chris, given what you've learned, what, oh, you have a hand up?
Yeah, sorry, hi, I'm Program Director of Got to.
Well, Caroline is there.
No, maybe as a, a longer memory, we actually had to close and move a lot of the sites in Zambia to make sure that they were in high density and
High poverty.
areas. And that is also problematic at times to set expectations and sites and then the close them. But, for a greater reach and a lower cost per collection, it is something we do. But also because we often work in mental health sites, services were made, but we moved our outreach out as well. So it was a big move by the program. Sorry.
No, it makes sense. There are a lot of sites that were done post that intervention. So Chris, given what you've learned, what would you do differently?
I hope that question doesn't assume I have ultimate decision-making power at the FCDO. But no, I think I highlighted in the presentation the key things that we would think about. So I think one of the main ones is probably thinking about when you're designing a mechanism like this, kind of thinking through the real-world risks and making sure that kind of the risk is set at the right level to incentivize the increased the performance you want to see, but without potentially being punitive, particularly when when programs kind of meet the reality of real-world programming, and you've got situations like the COVID-19 pandemic. The risk can be a lot greater than you envisage. So I think that would be a key thing if we were back at the beginning of the project that we'd maybe do differently.
I think I have a minute for Lamia. Lamia, you talked about client exit interviews and an assessment of how IPs have used this routinely to be able to track their progress with regards to these equity indicators. So in your opinion, and I think you briefly mentioned this, but do you think client exit interviews are a good way to collect data on clients' poverty levels? And in that sense, were there any gender-related differences in the responses from your study?
Thanks a lot, Joyce. So to your first question, the multi-dimensional poverty index and the poverty probability index are both quite well-tested indices. However, it should be noted that they were designed to capture data based on observations. So they had to be tailored for the purposes of being used in a client exit interview setting, particularly where it's being delivered in a facility, it's collecting data at a service delivery facility level. So there is no means of kind of observational verification. However, I think it's an interesting question because it's worth reflecting on the right metrics and indicators that we need to have in place in order to kind of facilitate that shift, because obviously we wouldn't be able to send enumerators knocking on every client's door doing household visits. In terms of your second question about gender-related differences, so we did actually encounter an interesting one, which is that enumerators reported that they felt women and adolescents answered their poverty questions more truthfully, and that men, when asked poverty questions, kind of felt a sense of shame. It's worth noting that we used both male and female enumerators because it was just difficult to have enough focus group discussions split by sex. Thank you.
Thank you. That's interesting. I think that's all the time we have for today. I guess if we all see, equity is not necessarily a straightforward business. There's a lot that goes into it, but I hope you've heard about some of the innovations, how we've simplified some of these innovations in ways that brings services closer to the those most in need, and ensuring that we're contributing in our own little way or big way to leaving no one behind. That being said, I'm sure our panelists will be interested in you interacting with them, ask them any questions that you're not able to ask. And just a round of applause for them. Thank you for that. And it's been an honor moderating this session, and we look forward to talking with you guys after this. Thank you, guys. Thank you.